When faced with a cancer diagnosis, it's natural to have many questions. Is the recommended treatment the best option? Will the chemotherapy or immunotherapy drugs be effective? Are there any natural substances that could complement the treatment and improve outcomes? What if there was a way to answer these questions with more certainty? Imagine a diagnostic tool that with just a simple blood test could provide a report on which chemotherapy or immunotherapy drugs would work best for your specific case. Wouldn't you want to know? This podcast explores that very possibility. I'm glad to host Dr. Ioannis, founder and director of RGCC Labs, and Dr. Mandeep, a renowned head and neck surgical oncologist from India who has successfully integrated RGCC tests into his clinical practice. Together, they'll guide us through the world of personalized medicine and explain why it is becoming an essential part of modern cancer care. If you haven't already, check out our video featuring Mrs. Manoroma, who was diagnosed with stage 4 colon cancer. In it, she and her husband share the journey of using RGCC reports to heal their cancer naturally. You can watch the full podcast and video by clicking on this link. Hello, Dr. Mandeep. Hello, Dr. Ioannis. How are you?
Fine.
Very fine.
So,
I'm glad to have you here at this podcast. Thank you so much.
sure.
I'm really excited to talk to both of you, because whenever someone is diagnosed with cancer, the major problem is that they are not just financially but emotionally and physically challenged. And one of the problem is that accurate diagnostics, which leads to a lot of treatment decisions. If the diagnostics are not proper, then the treatment decisions follow the same. So, you're a wealth of information on diagnostics, and Dr. Ioannis, you're the pioneer in personalized medicine, right? And founder of RGCC Labs. And Dr. Mandeep, you have 20 years of experience as a neck and head surgical oncologist. So, you have clinical experience as well as diagnostic experience of how we can integrate all of this to make the lives of patients better. So, thank you so much for being here for this. Before we begin, just how was your stay here in India?
Well, as usual, I'm always impressed mainly by the people.
Great.
And they speak their mind and from their heart. So that's really impressive.
Amazing. How's the rain treating you?
Well, surprise, surprise. So for me, I haven't used these kind of climates, but nevertheless, still this doesn't change my mind for the country.
Amazing. So, before we delve into the main questions, for the viewers, specifically because they're looking forward to some questions, I would like to you, Dr. Ioannis, first, that when we talk about diagnostics, we generally come across biopsy or mammograms or, PET CT imaging tests. But we never talk about personalized screening. So what exactly is personalized cancer diagnostics and how do we define CTCs?
Well, personalized diagnostics is a very, very broad spectrum definition. It means that we have to use any available method and technology in order to obtain information for a single individual. That means that our approach for a single person should give us credible data information, as well as the method should be very sensitive so that it will be capable to identify the disease precisely and very early. From the conventional diagnostics that we have, as every diagnostics, they have what we call limit of detection. They cannot see or detect anything below one limit. To give you an example, an ultrasound can see, let's say, a tumor or let's say anything abnormal inside the body which cannot be less than 1 centimeter or even more. The MRI and the CTs can be around the same limit of detection. The PET CT can go a little bit further, 0.5 centimeter in diameter. So whatever it's below or lower than that limit cannot be seen, cannot be detected. So this is the reason why we have to go on more sensitive techniques like molecular biology based or cellular biology, which the limit of detection becomes extremely low. So practically you can see a few hundreds or a few thousands of cells inside the whole body. This is what makes all the molecular techniques very favorable. Now, because the people are not identical each other, and equally the tumors are not identical between individuals, and even the tumors inside the same individual do not behave the same. This is what we call heterogeneity. This makes the need of identify all the data from all possible sites as accurate we can in a relatively early stage, so that we will have the chance to treat the patient successfully. So, and these are the challenges in precision medicine, in personalized medicine. So we take not only one but multiple approaches, multiple tests, in order to obtain this plurality of data, which may be a little bit complex or a lot of complex, and at the same time we have to translate them to without losing any value, to data that means something to the clinicians. So this is the challenge, and this is the fact for personalized medicine nowadays.
Got it. So when we started this, so you had some experience before this when you had this comprehensive test of Onconomics Plus.
Well, Onconomics Plus is, let's say, a combination of methodologies, and it's not only one. Yeah, to the outer world, it seems like one test, so one methodology. So actually, it's not. It's a multi-layer process, sequential one after the other. The first thing is that you obtain the biological specimen, the biological sample, which is blood, and then you have to identify the circulating tumor cells, which they may be shedded from the primary tumor in early stage. The preferable method is to use what is called negative selection. You take all the unwanted cells which are blood origin out of your equation process, and whatever remains at the end includes all the subsets of CTCs, which, as you can understand, it's not one entity, it's composed from different groups. Then the cells are expanded in tumoroids, in 3D cultures, not as we know them, so that they will give data which represents the human body as they have been extracted from the person. And from these cells, a part is going for what is called transcriptomic, what is the gene expression level above or below the original and healthy tissue of origin that the tumor comes from. And all this data, which we're talking about a transcriptome of approximately a little bit less than 30,000 genes, we confirm or reject with viability assays. So we return back to the original cells, we expose the cells to the drugs that we use in the daily routine, to their active form, and we see how well they actually work. So all these data are accumulated, they are converted and presented in a relatively easier format so that they will have a meaning to clinicians. And at the end, we are there to support them to interpret the results and make the right choice for the individual.
Got it. Got it. So, I mean, this question is for you, Dr. Mandeep. So, in India, and I think a lot of doctors must be, having this question in mind, that compared to the tests that we have today, right, the tests which Onconomics Plus or, the other tests which RGCC offers, it provides a lot of insights about chemosensitivity, natural substance sensitivity, gene analysis. So all this information is relatively not, we are not educated about that on a very in-depth level. So when you started integrating this in your practice, so what challenges did you face when it comes to integrating this?
So, as an oncologist, obviously when you go into clinical practice of oncology, so what we realize is that all our guidelines, all our standard methodologies like surgery, radiation, chemotherapy, first line, second line, these guidelines, that guidelines. So yes, but when you come to practical application, first of all, in spite of everything, we are not able to save all our patients. A lot of patients or our patients would have recurrences, relapses, in spite of all the best standard practices. One thing. Secondly, there's a lot of toxicity with the standard practices. Like when you go into chemotherapies, so we have to see whether the patient is able to tolerate that, what are the side effects of that, and also when you're looking into radiation, what how the patient is able to take it. Again, post. So a lot of times in my early days of practice, like if I have a patient whom we are looking into advanced cancer patients, my medical oncology colleagues are looking into chemotherapy, the patient going into neutropenia, septicemia. That is obviously terrible. And then patients lose faith in this kind of therapies and then they leave treatment. Right. Surgical issues are also that very extensive surgeries, and then it's a lot of morbidity associated with it. Like if I have a extensive oral cancer, I do a big resection, so and then the patient is not able to speak, the patient is not able to eat, and what kind of life that is. So when we started looking into it's not integrative, we were trying to find ideas or options to make things better. Now I was introduced to high dose IV vitamin C. One of my patients only introduced me to this, and when I started reading about it, I found it very good. It's like, so if a high dose IV vitamin C, who in patients whose creatinine level is fine, whose G6PD is fine, who's not diabetic, and if I add a high dose IV vitamin C to my chemotherapy regime, so what I'm achieving? I'm achieving two things. So the reactive oxygen species increases, and specifically all a majority of chemotherapies are platinums, taxols, doxorubicins, gemcitabine. And there's a lot of data which says that high dose IV vitamin C increases the effectiveness of all these chemotherapy regimes. So first of all, I'm able to achieve. So if I'm giving a high dose chemotherapy and I break it down to a low dose weekly chemotherapy, so my IV vitamin C may achieve a better effect than what a high dose chemotherapy would achieve. So the toxicity becomes lesser, the effectiveness becomes better, and if I add all these things, then it makes life simpler for me, it makes life simpler for my patients. Then we have a lot of research when we look into other things like natural substances like curcumin, like genistein. Then when we look into off-label use of doxycycline, of mebendazole. Now, mebendazole is something which is very good to prevent metastasis. Doxycycline is a known thing to go against MMPs. Right. But the thing is that there is no way scientifically I can integrate that. And a lot of my friends would not agree with that. And then if I advise some of my patients, then obviously at advanced stage of cancer patients, and obviously we are not perfect, so there would be other people who would give opinions, and then there is a negative opinion, then there is a positive opinion. So how the life changed after RGCC was, first of all, yes, in practice, I'm still not at that stage where I'm using RGCC for a primary patient of mine. But yes, I'm looking at RGCC when if a patient whom I operated, I treated, my team operated, or that patient has been treated somewhere else and there is a recurrence. Okay. Now, when I'm looking at a recurrence, so obviously so what is being offered? A second line chemotherapy, immunotherapy, that's checkpoint inhibitors, some targeted medicines. That is what we offer. Now, when I'm looking at second line chemotherapy, and if the patient doesn't respond to second line, then when we go to third line, the patient is already, right, the toxicity of chemotherapy is very high. The bone marrow resolves goes for a toss. So I might not be in a condition to give third line chemotherapy, and patient might not be in a condition to take third line chemotherapy. So if I'm able to pinpoint, yes, this is a guideline, and in this guideline, if I'm able to understand that no, this is a better drug, And out of the two drugs, if I find that this is a less toxic drug, or this is more easier to give, it is more, so I might choose that. Secondly, RGCC is the only test which gives me some idea about why the patient has failed, or why if I give chemotherapy the patient will not respond. There is no other NGS analysis or any analysis. Like for clinicians, NGS, DNA, 100 genes, 500,000 genes, 10x to 3x, it is all Greek. It doesn't make a difference. The only difference which makes to us is that there is a report. Can I do something for my patient? Now, whether that report has been generated in X way or that report has been generated in Y way, the ultimate test is that it has to benefit the patient and it has to make my life simpler. So it lets us know whether if there is a high expression of MDR MRB, so I'm able to understand that even if I give the second line, even if I give this drug, still there are very high chances that my patient will not get a response because the resistance is very high. And then when we started looking into how to get the resistance down. And then when we interacted, so it's just a recent interaction with Dr. Ioannis, and I was able to understand why that no particular target of MDR can be made or should not be made, because it is a generalized thing. But yes, the cancer cells would be expressing it higher. So natural supplements, quercetin, flavonoids, genistein, drugs like ivermectin, verapamil. So if we add all these things, so the resistance will go down. Then I add a particular chemotherapy, so it will make life better. The chances that it will respond is much higher. I add a high dose IV vitamin C or certain off-label medicines like mebendazole, doxycycline, or even metformin. So that might increase the response. Obviously, when we do look into factors like high dose IV vitamin C we'll be giving during the half-life of chemotherapy because it's a pro-oxidant. Whereas majority of natural supplements are antioxidants. So that we'll be giving after the half-life of chemotherapy, so that it doesn't interact. We still don't have in-depth analysis of all these things, what interacts, what doesn't interact. So we try to be safe, that I should not be harming my patient. I should not be making a particular medicine ineffective by adding certain things. So what we know, what we don't know, and what is our safety limits, we try to practice that. So, and there is no other way. I haven't seen anybody else even looking at IV vitamin C. And if the RGCC report actually shows that, so I'll tell you how RGCC report, if there is a pembrolizumab or a bevacizumab and the inhibition in a pictograph, it would be 30%, 15%. And then there is ascorbic acid which has an inhibition of 35%. So as far as my inference is that ascorbic acid at 35% is much more important than a bevacizumab at 10%. So yes, I'm not saying that we don't add bevacizumab. I am agreeing with my medical oncology colleagues, we do add it. But if I add high dose IV vitamin C to that, it might benefit it more. So, and that is a scientific, at least there's some report, some tumor viability assay, which gives me this authentication to add IV vitamin C. It also gives me certain, so people ask, and then there is a lot of whether mistletoe can be given or not. Now, what I have normally found is that if I have, as a concept wise also, mistletoe is an immunomodulant. It's modulator, and it improves the immunity. But if I'm looking at certain things, like if I'm looking at a checkpoint inhibitors or a targeted medicine or a vaccine, and in that case, mistletoe works better. And when I look into RGCC reports, the confidence I get is that in patients in which we are looking at more role of checkpoint inhibitors, we are looking at role of mistletoe. If that doesn't work, this also doesn't work. So more or less, it gives some scientific evidence that this is what is working, this is what not is working. So it helps us to formulate something which is more applicable. It is more reproducible. Secondly, there is some certain basis of certain things, and this helps me. And like if a patient comes to me, I have an RGCC report, I start a treatment to that patient. I'll give you an example today itself. So there's a patient who came to us from Kenya. So stage 4 lung cancer. treated with checkpoints, chemotherapy, had a progression. We got the RGCC. We understood that the checkpoint which that patient was taking, the other checkpoint which was cheaper was better. The chemotherapy regime which that patient was taking, this drug would have been better. So we changed the drug, we changed the checkpoint, we added a targeted. There is a response. We looked into vitamin C, and there is a protocol. So we got a response. I discussed the same protocol with the doctor in Kenya. Now, with the response, with an RGCC report, with a protocol, the doctor in Kenya assured me that they will follow the same protocol what we gave it. So that is what RGCC gives us. It helps us to propagate this kind of treatment to my other colleagues also. Until unless they see results, they see a report that says, like if I just vaguely talk about curcumin, nobody would believe it. But if I talk about curcumin, I have a report which looks into curcumin. I have a case story which there is a response to curcumin. Whether the doctor, when the patient goes back to the other doctor, whether that doctor actually translates into her or his normal practice is a different thing. But for that particular patient, that drug or that integrative approach would be practiced by the other oncologist. Because then there is a response, then there is a report, and then there is no way they would say that this is wrong.
So can we talk about the accuracy of this? As in, if certain, for example, you mentioned Berocimab. So, if we talk about this drug or cisplatin, whatever it is, so if we talk about this and there's a high sensitivity to cisplatin. Now, if a patient has actually applied cisplatin in his during the treatment, so the results are better compared to what his practitioner is giving. Can we say that?
There's no head-to-head trial that I can say that cisplatin through RGCC, or he might have used cisplatin normally also. So we will not have that head-to-head randomized data to say that this is the way which is better or this is the way that is better. What I normally feel is that yes, if something which works in vitro, and as Dr. Ioannis has explained that this is basically they're looking into tumoroids, and this is how a new drug development is actually happening. So if we are getting a new drug based on the same concept, and why don't we test the original, the drug which we are practicing in the same concept? So in my practice, I would say that 70% response rates in a recurrent setting, in a stage 4 settings, I'm happy to take that. There are times which we have failed. There are times that the patient has not responded. The good part is that I'd also tell you one more thing. I get a foundation 1, right? First of all, to interpret foundation 1, if we don't find anything, it becomes difficult. Secondly, if I use a drug based on foundation 1, I do not get a response. There's no way I can get back to them and interact with them and say that this is what the report was, this is what I did, and the patient is not responding. What shall I do? At least in RGCC, if we do something, we get back to him, we say that this is what we have done. So, and you will feel that this is, something could be better, and the patient has not responded. So, are we doing it right? So, at least he gets back to us. And Dr. Ioannis, one thing is very important, that particularly that as somebody who looks into cancer from the molecular part, and also when come back and gives an on-ground part of the treating team, it becomes a lot of the difference is there. And so stage 4 cancer, even early stage cancer. So what we say early stage cancer, if it is stage 1 breast cancer, what do we say? We say 90%, 85% cure rates. We never say 100% cure rates. So even at early stage, we say that cancer is something which we still understand just tip of the iceberg. There's a lot more to learn, and we are also learning through, and RGCC helps us to learn in much better way.
Got it. That's good.
In practicality, all the lab tests, not only what RGCC offers, but every lab test gives only, at least of this kind, gives only the part of how effective the drugs may be. But the lab cannot be able to know What is the clinical actual status at the present time of the patient? What is the, let's say, the ability of the patient to metabolize the drug? How well the kidneys are working? What is the liver function? So these are parts are missing. So the lab will give options, but to translate them on a therapeutic protocol means that you need both sides. You need the clinical side as well as the actual, let's say, assessment of the tumor itself.
Right.
This is what Dr. Mandeep is actually describing, that, yeah, the lab gives options, but not all of them are feasible to be done. And since we ignore the what is called pharmacokinetic, so how able is the patient to tolerate or metabolize or activate the drug, this is critical for making decisions. So the interaction becomes essential.
Right.
And this is what actually missing. I believe with a very good communication and support in the clinical field, this can be achievable. I believe this is the paradigm. So the sensitivity of a test always relies on how you transfer your data to the bed of a patient. That's it.
Got it. Can we, especially for patients who are, visiting for the first time to a practitioner, if we directly give RGCC without providing any other tests, how effective would it be to provide a result? Dr. Ioannis.
Well, the principle in medical oncology is never change a winning team.
Okay.
And we have to say that it would be nice and very ideal and a very noble one if we can apply personalized medicine, our test or any other company's test, on early or naive diagnosis with cancer patients. But on the other hand, we know very well that naive patients respond well up to an extent, up to a big extent, to the already existed protocols. We have to be realistic and live in this world. So we have also to consider the costs. Why someone should pay a test which 90% it will take the same thing that the protocol will introduce. So it's really waste of time and money. But when the disease becomes more systematic or recurrence or refractory, this is the proper time to start thinking personalized approach.
Got it. So what's your perspective on this?
It's very similar. That early stage cancers, first option should be the standard treatment and see whether that patient is responding or not. Because as my limited experience with RGCC also is that majority of times it does concur with the standard guidelines.
Got it.
So yes, and for early stage cancers, for naive patients, the better option is that you go ahead and give the standard treatment and see whether it's responding or not. The only utility which I feel the RGCC can offer in early stages is something that, like supposedly now we have seen that there's a lot of role of checkpoint inhibitors in even using at early stage. And when you're looking into checkpoint inhibitors, so the patient who is looking into a checkpoint or a targeted or a drug conjugate at very early stage, and they're able to, and they are looking into getting all those things into their treatment. So then it makes sense that if we are able to analyze and understand that if they have the role of all these drugs, and so in that phase, yes, RGCC can be an option. Yes, so if I'm looking at a very expensive kind of drug conjugate or a checkpoint or a targeted kind of medicine, and I'm looking at the patient is about to spend an X amount of very huge amount of money, and if RGCC can help me to understand whether this actually works or not. So this definitely is a role, but otherwise standard of care is still the option.
All right. Okay, so one question, that generally patients have is the sensitivity, is how frequently we should get the test and whether the sensitivity will change after a while or not.
Well, from the data that we managed to collect, we know that cancer is adaptable, fine, but we shouldn't reach the other extremity, which means that every time that I'm I'm doing a treatment or in any cycle, the cancer quickly adapts, it changes completely, so I have to redo the test. What we have seen is the following. Cancer requires a period of time in the specific, let's say, frame of exposure to a treatment in order to develop a recurrence or develop a resistance. So, for instance, a patient is doing the test, so we take the chemosensitivity, we do the translational part of the analysis, we create a protocol and we treat the patient. If we have the bad luck and recurrence is happening, if it happens in a short period of time, let's say 6 months or shorter than your treatment, but you have seen originally that the disease is responding, so it's better to stay on the same treatment, probably because the patient hasn't been treated enough.
Okay.
And the cancer doesn't have the sufficient time and exposure to develop a secondary resistance. But if your recurrence comes after 6 months of the last therapeutic intervention, so it's more probably, let's say, after a year or a year and a half, so probably we are talking about a different behaving cancer.
Okay.
Then that is the right timing to do the analysis from the beginning.
Okay. So after, if I interpret it correctly, after 6 months, if the patient is going on some treatment, right, after 6 months, the sensitivity might have a little bit of fluctuation. But before that, if he's on the same treatment path, the sensitivity might not make a very big difference.
Correct.
Right. But if he changes the treatment path, then the sensitivity might also change.
Correct.
Got it. So after, 6 months is the standard time that one should get from one report to another report to see if there's any fluctuation or if there's any modification in the genes.
Correct.
Or the sensitivity of natural or chemo.
Basically, the thing is that if the patient responds, like we gave a treatment and we get a response. So in that case, what we practice normally would be that we just get the tumor markers or an onco count, or so that we can understand that what was it and what is it now. And obviously, when you get the RGCC, so there's a protocol in which there's a cytotoxic chemotherapy or a checkpoint inhibitor which is made for a particular time, and then there are certain standard of care medicines or even nutraceuticals. So then there is a upfront initial acute management, and then there's a maintenance management. So acute management is done and we are putting it on a maintenance management. So we put the patient on maintenance management. So in maintenance management, if the graph is going down, then we are on the right path.
Okay.
So as Dr. Ioannis said, that you don't change the winning team. So if it is going down, maintaining, then we don't ask to get the whole analysis again. Now if the cancer starts recurring, or that is when we ask that if you want, then also is an option, because it's resources and everything, and what is the patient's will to go again for another kind of treatment. So that point of time is then we ask for the whole analysis. So that is how it becomes cost effective also, and it is more reproducible also, because just getting an onco count is not very expensive.
Got it. So, this was really fantastic. So, can you just help and share some examples of how some patients, responded to this after you have, used?
I'll share a few examples. Like, so there was a patient who came to us. So she was a young female, BRCA positive, being treated for past 2-3 years. Initially, she was being on. So she had taken all the lines of chemotherapy, checkpoint inhibitors, targeted medicines, PARP inhibitors, not responding, having liver mets, everything. So what we understood, and the biopsy again coming at the primary side biopsy coming again as a weak hormone positive and a triple negative variety. Then we got the RGCC done. So what we found was that the patient had initially not, so the initial simple idraromycin cyclophosphamide was the most sensitive drug, and also there was not much role of any checkpoints targeted and all. And the patient, when she came to us, she was in ascites. The liver was actually palpable. The LFTs were going down. So we just started on a slow doses of adriamycin cyclophosphamide, which we thought that, unfortunately, within 3-4 doses, the liver was not palpable. The ascites had gone. And all of my colleagues, even myself, we were. So what happens is when the cancer recurs and the cancer doesn't respond, so if this doesn't respond, the other one will respond. This doesn't respond, this will respond. So the cost and the fanciness of the drug starts increasing. So that patient was looking at US to get that Sictuzumab, the new drug. So they were waiting for that to go to US and get that, but they could not afford it. They were not getting a trial, and just simple AC started working on them. So that is one thing which we analyze. So this is some. So we never. What I am sharing is that we never thought of those lines, that we should go back to more simpler things rather than more complex things. Another patient was an oral cancer. So a posterior tongue cancer, given chemo, all chemos, then after that transoral robotic radiation had a recurrence. Now what happens is that this was a posterior tongue recurrence, and thrice we had my colleagues had attempted an endoscopic biopsy, but the biopsy was always negative. The MRI and the scan started that the growth is now 6 centimeters, and there was no mouth opening. For us, there was either we go and take him to the theater, give him anesthesia, then do a biopsy, or take a blood sample and get the RGCC. So that the simplicity of having a blood sample and getting a biopsy is one thing. The other thing was that we were able to understand now that there was not much role of checkpoints or immuno, but role of a bit chemo and a targeted was much higher. So we put him on that, and fortunately a posterior tongue post RT oral cancer. So oral cancer post radiation, it's a normal dictum that 90% of times it will not respond to systemic therapy. It is said that the cancers which recur after chemo radiation are not chemosensitive at all. So that patient responded very well. We were able to do a surgery which was less morbid. He's able to eat, he's able to talk. So that is another example of it. Yes, when we looked into RGCC, we also looked into the maintenance regimes of nutraceuticals and all. So we got a chemo, we put him on some targeted, got the surgery done. Now we made a chalk out a plan that these certain off-labels and nutraceuticals can be used for maintaining it, to maintain a recurrence free. Another patient, ovarian cancer. So primary ovarian cancer got treated 2 years back, induction chemotherapy, then complete cytoreduction, then completion of chemotherapy, then PARP inhibitor maintenance and all, now recurrence. So initially they had a question that, so there is a data which says for and there is a data which says against HIPEC also. And initially they were confused whether they should go for HIPEC or not during the first CRS. Now they had another recurrence. So when we looked into another recurrence, so this was another after 2 years. And she also had a stroke, history of stroke. So standard of line says that you go into Taxol platinums with bevacizumab, that is standard case. And there's a lot of apprehension of that with stroke whether we should give this or not. So so to take a drug like Avastin or bevacizumab in a stroke, so we have to be very sure that it should be beneficial to the patient. So patient had ascites, this is liver mets, the liver deposit ascites, not able to eat well. So we were able to understand that this patient, so normally we treat ovarian cancers as platinum resistant, platinum sensitive. So this we found out that it is still platinum sensitive, but not Taxol sensitive. So this we would have never thought of. We would have just thought that let's try Taxol again. So we are more focused on platinum resistance. Our focus on Taxol is not there for ovarian cancers. So we were able to understand that yes, this is Taxol is not working, gemcitabine is not working. Yes, so we should go for the second line doxorubicin and with platinum. So doxorubicin with platinum, and then we were able to understand that Avastin was still 30% effective. So we took that chance that this patient would benefit from Avastin in spite of having a stroke, a low dose 200 milligram Avastin with Lipodox platinum. Within 4 cycles, we were able to achieve a CR.
Amazing.
And then obviously we gave the option that whether if, so we had referred them that if to a expert in HIPEC, that now is the time whether you can consider HIPEC or BIPEC, because the RGCC helped us to know that HSP proteins are on the negative side. So if HSP proteins are on the negative side, so in HIPEC, if you increase temperature, so the uncoiling will happen, and whatever peritoneal cells would have been left behind, they'll be able to take care. Secondly, we also understood that platinum is still working. So platinum based HIPEC will work for her and keep the response for a longer time. Otherwise, when we withdraw it, it will come back again and patient will again have ascites.
So how long did that patient take?
The patient is now has been referred for she's choosing a PIPEC. She's doing fine.
Wow. So that's the power of RGCC test.
Well, not a standalone, as you realize. You need to have other modalities. So
Right.
here we combine Dr. Mandeep's team actually put other approaches. So it's not always, you have to put systemic therapy. So PIPEC, HIPEC are considered as local-regional approaches. So this is also possible to implement in a cancer patient as long as you want to avoid toxicities and good effect in a local compartment. So that proves one thing, that cancer management is not one-man show.
Right.
It's a teamwork, and we require a lot of disciplines to come under the same table and exchange in an equal manner all the data available for any single individual.
And data is extremely important when it comes to oncology.
The best part of the thing is that now, the good part of RGCC is that it helps as a team. So another example I'll share with you. So we had a patient of lung cancer, which we were discussing, and the patient has a good response. Now, so we gave checkpoints, we gave chemo, we gave off labels, we gave high dose IV vitamins. The patient at one point of time has responded. His PET scan shows bony lesion sclerosed. The primary site, there's no uptake. So how do I maintain it more? So then obviously there is a dilemma. Now, when the patient has responded, whether I should go for a radical surgery, I should address the primary or not, and how to address the primary. So what we were able to figure out was that yes, we should address the primary. So addressing the primary would help us to maintain the response at a much. And we were also able to understand that since an HSP expression is less, so this is a very radiosensitive situation. So rather than going for a radical kind of a surgery, it should be better that a simple 4 fractions of SBRT can solve the purpose. Similar lesion, a brain met, solitary brain met, responding very well. After that, the patient develops a brain met. And then also we are able to, yes, it helps us to make, now for a stage 4 patient, we would not be looking at doing radical lung surgeries or neurosurgery, because we don't know how much survival benefit that patient would actually have. But to take decisions for non-invasive methodology, it becomes easier for us. Yes, this is a non-invasive methodology. Go for it. You'll be benefit. I share one more example. So there was a patient she had an oral cancer recurrence. She was operated once, then she had an oral cancer recurrence. And she was like, I don't want to get surgery. So it was definitive that no, there is no debate that for an oral cancer, surgery should be the treatment of choice.
Okay.
No, but the patient was not willing to get surgery at any cost. Now, what is the option? Leaving her to die? No. And then we were able to understand that yes, now another issue with oral cancer is that as a conventional thought, oral cancers don't respond to chemotherapy. The role of neoadjuvant chemotherapy in oral cancer is not limited, it's not found beneficial. Oropharynx, it's a separate issue. For a primary oral cancer, we don't prefer neoadjuvant. So then we were able, and the patient again had a lot of resources, was willing to go for any extent and looking at immunotherapies, even some vaccines and all. So got the RGCC, we were able to understand that not much role of checkpoints, but a better role of simple chemotherapy with anti-VEGF or anti-EGFR. Gave her that, got a very good response, and with a low HSP, we asked the patient had resources, so the patient chose proton over SPRT.
Okay.
So the patient got the proton and she's doing fine. So yes, now we were able to understand that this is this is an unconventional anecdotal experience. Obviously, this cannot be extrapolated to other patients. But we were able to understand that yes, this is neoadjuvant therapy which should work for her. It worked. This is obviously, or as an oral cancer, it becomes very difficult for us to choose primary radiation because you have very high chances of osteoradionecrosis and recurrence also. So we were able to understand that disease has responded very well. So when we sent it for proton, the PET scan showed a complete response. There was no metabolic uptake. And when we gave protons, obviously we were addressing to maintain it in a bigger day. So yes, this is kind of a very, so this is exactly personalized treatment.
Right.
And this is what actually sometimes patient drives us for that. Now patient was hell-bent on no surgery. Patient was that I would like to go for non-surgical options. And then with a low HSP, we were, now if that patient is spending so much on treatments like proton, so, and if we are able to figure it out, yes, proton would be beneficial rather than a surgery. So yes, it gives us more confidence. So that is the path which sometimes RGCC helps us to understand it and take a decision. And now I'll tell you, Dr. Ioannis, this is for you. So my colleague, so in India, the proton is in Chennai. So when the patient went there, they called us back. Why don't you operate? This should be surgery. I said the patient is not willing for surgery. I would have operated, but he's not willing for surgery. That she was not willing. So I said, look into the RGCC report. The HSP is down. If the patient is radiosensitive, the patient will even benefit from your therapy. Just go ahead and do that.
So, yeah, that says
So that helped me to convince them that you are also on the right path. Yes, this is not standard of care, but this is personalized medicine and this patient will benefit. And the patient actually benefit.
Well, this is what it is about, because the data are coming out from the same individual that you intend to treat.
Right.
So you cannot have more credible data which are related with his condition. This is the beauty and the difficulty at the same time.
So we are not able to conduct large-scale trials.
Well, let me put it in simple manner.
Yeah.
Trials mean that I'm going to have at least two arms, one control and one which is the novelty, and I have to compare them on different parameters. Response rate, time to relapse, overall survival. These are the main three parameters in oncology. Fine. But this is very to control, because you compare identical things, apples with apples, orange with orange.
Right.
How you're going to make a trial when all your data and all parameters are tailor-made and are fluctuating, and put that on the same concept. Mathematically, it's not correct. And this is the challenge in personalized medicine. That's why we cannot see much of data out there of these kind of completely tailor-made to single individual trials, because there is no mathematical model which can describe them well.
Got it.
So this is the fact.
And I think this is the challenge that because of this, we're not getting much acceptance of, I won't say acceptance is not the right word, but I would say that more and more practitioners are not using this currently because, because we're not able to generate these types of trials.
Correct. And on the other hand, yeah, it requires to devote time to develop other kind of skills, and yeah, it requires teamwork. So pretty much, if you have used to be on let's say, to the empirical approach, you are in a way on a comfort zone. If you go to the personalized approach, you need to put a lot of effort. So it's a matter of where you want to stand.
So, you're one of the few oncologists in India who's, actually using all of these, approaches in treating a person. So, first of all, it must be difficult because it might require a lot of time when it comes to approaching, personally and developing protocols for each patient.
So it's not me. It's just that I'm talking to you. There's a lot of people behind me. So there are 2, 3 medical oncologists who work with us, who understand RGCC, who help us to decipher that, which chemotherapy protocols we are using. So I'm a surgical oncologist. I'm not the guy who would looking at chemotherapy. So they look into the RGCC reports, they look into the standard guidelines, and they help us to develop a chemotherapy protocol. Then we have a lot of research scientists with us who actually look into what nutraceuticals are there in the RGCC, what are the pathways which are being expressed, and then what are the interactions with the chemotherapy drugs which we are using. And then they help us to develop the natural complete protocol. And yes, I am just a coordinator of making things, like I shared with you the story of a oral cancer. So I was able to coordinate the medical oncology and understand that this is it, coordinate what nutraceuticals would have done, and then ultimately coordinate with the proton therapist so that all the medical oncology, the nutraceuticals, the proton all came into things. So that is what I do.
But how about, when it comes to approaching in a hospital setup?
So hospital setup, yes. So I would actually, so we uh, give credit to CK Birla Group. So CK Birla Group actually gave us the approvals, necessary regulatory approvals to start. So so they gave us that, okay, use IV vitamin C. So the medical board cleared it since there was no harm in it. And then they actually saw the results. Then certain therapies, like if I'm looking at ATA or a Vaxocure kind of vaccine, so they were able to help us because this is a personalized for a personal patient. So they helped us to take those to help us that regulatory support. Yeah, this is what it is. And yes, if we are looking into some trials, then they are proactive in developing these kind of things. And now, since in India, specifically in country of ours, that we are looking into uh, cancer as a whole. So it's just not chemotherapy which will work, right? It's just not surgery it will work. So all of us now accept that there is a certain role of alternative medicines, there is a certain role of nutraceuticals. We are just trying and so what has helped us is that now there's a lot of research. So if I'm talking about curcumin, it's not a vague thing. I'm talking about genistin. It's not a vague thing. Recently, Tata came up with a trial of resveratrol. So, and I think for past 2 years, when I'm looking into RGCC reports, they are giving us the option of using resveratrol or not. And what did actually the trial data showed? It prevents recurrence. Yes, this is it. The nutraceuticals actually helps us to take the maintenance to a longer period of time. So that is what now it is proven that it helps to prevent recurrence. So what is they are looking at? They are looking at the resveratrol would actually prevent, so that it works on the H-TERT. So it would promote the apoptosis of cancer stem cells. And this is a proven fact. So that is how we are able to help us. And then with Ministry of Ayush and all, with the environment in our country, that we are looking into options which are obviously standard of care, and options which help us to make standard of care better. For me, it is, I would take curcumin if it decreases, it makes my chemotherapy drug more effective. It's a proven fact. It decreases side effects. Yes, I would take it. I would, so if these certain things even decreases the incidence of neutropenia, I would take it. So this is how I look into these things.
What advice would you like to give young aspiring medical oncologists who are willing
It's
to...
not medical oncology, surgical oncology. So whether it's a surgical oncologist like me, whether it's a medical oncologist, my colleagues, or radiation oncologists, the first 6 chapters, that is understanding cancer, disease biology, neoplasia, disease pathways, genetics. In normal trainings, we don't give much weightage to that. So I credit to my teacher who actually, when we had tumor boards, so when I was in my head and neck fellowship, so head and neck oncology fellowship, so my teacher who also happened to be, so it was Dr. Muni, who is the head of translational research at Redwood Park. So he made me attend my clinical tumor boards, and he made me attend, and for me it was more important to attend the molecular board or molecular journal. That is how we started developing these interests. So understanding disease biology is very essential for any person who treats cancer, whether it's medical oncologist, whether it's surgical oncologist, whether it's a palliative care, whether it's a radiation guy. So we should actually, when we start looking into understanding cancer as a whole and understand the disease biology, it helps us to make its treatment better. Just a small example. When I was in my training, for me, an early stage breast cancer means surgery, right? But now, when I understand, I'm not talking about RGCC, a simple thing.
Right.
I have an early stage breast cancer. If it is a hormone positive, ERPR positive, HER2 negative, I'll go ahead and operate. Now, operate can be you do a mastectomy, you do a breast conservation, or even use a robot. I use a robot to choose breast, yes. And I'll do a risk assessment and see whether it's high risk, low risk. If it is low risk, I will not even use chemotherapy, I'll just use hormone therapy. But if it is HER2 positive, or if it is a triple negative, even if it is an early stage cancer, even if it is a surgically feasible, early stage means surgically feasible, I'll still never operate. I would give systemic therapy first. So even if my patient is a HER2 positive, so whether that patient takes trastuzumab or trastuzumab with pertuzumab, if it is a triple negative, Taxol platinum with pembro, it doesn't make a difference. But I want to be sure that whether this patient is a responder or that patient is a not responder. So if I operate upfront, I would never be able to categorize the patient between responder and a non-responder. And if the patient is a responder, the recurrence rates are very less. If the patient is a non-responder, the recurrence rates are high. I should be proactive. So this is the disease biology. So my same decision of doing a breast surgery, if I understand the cancer disease biology, helps me to change that and make it more effective. And if I err on that stage, I miss the opportunity of an aggressive disease like triple negative breast cancer, and I go ahead and operate it, and I'll never be able to give my patient that option to categorize it between responder and non-responder. And if I miss that, I actually miss the whole thing when there is a recurrence. So yes, that is the disease biology which helps us to take the right decision at right times. And cancer genetics is open for all the 3 streams. It's not that medical oncology or surgical oncology, and the first 6 chapters is of the same curriculum in all the 3 streams.
True. Contributing to that is, we want the best possible options to be available.
Right.
To make a decision to any problem in our lives, no matter if it's medical or whatever, the first is to have a very good understanding of the problem. So that means I need to have an extensive information from the original data of it. So this is what we try to do here.
Right.
So if we miss that scope, definitely we have increased chances to make wrong decisions. So we have to become more flexible. We have to be more, let's say, relying on a single individual data instead of getting only statistics, which may not be always applicable to a single individual. So this is the tricky part, and we have to work on it. And additionally to that, we have also to think not only the patients of today, but as well as the patients of tomorrow.
Yeah.
if we do not obtain data from the present patients, we're not going to evolve further options for the patients of the future. So let's think about that and let's see what best we could do for the present patient, but as well as to help the future.
But that would mean that you would need more data from a lot of different doctors, different types of patients, different types of environments where there have been ethnicity and all that would probably influence that. So how are we how can we expand that to different doctors specifically? If I say because of the report that we generate, that has a lot of elements. So
well, let's make it more simple.
Yeah.
Always be driven by, let's say, by impression. So that means, I believe you have heard from Dr. Mandeep many success stories, which are quite amazing.
Right.
I believe this can be a triggering factor to patients and mostly to other clinicians to get involved. So it's a matter of willness, how someone wants to get involved in it. And eventually, if you want to create something bigger, you start from something small.
Right.
So someone makes the first step, like Dr. Mandeep, from the clinical part, and the others will simply follow the lead, follow the example. This is how the things are moving forward.
Oh, that's absolutely correct. It's fantastic. And I had a pleasure speaking to you both. I hope the viewers would have great insights watching this podcast. So thank you so much for your time.
Thank you also for the invitation. Thank you.
Thank you.
Thank you.
Okay.
I hope you found this podcast insightful and that it gave you a better understanding of how personalized medicine can make a difference in cancer care. If you're interested in getting the test for yourself in India, simply fill out the details here and the team from Neely Genetics will reach out to you immediately with information about the test and will also help you connect to the right integrative doctor as well. Thank you for tuning in and remember to stay informed, take charge of your health and explore all the options available to you. Until next time, take care and stay well.